Hi everyone, I'm Dr. Basili, your orthopedics faculty with Marrow, and today we will recall the questions that were asked in the NEET-PG of 2023. Now before we begin the recall, I would tell you that most of the questions were previously asked questions, and the paper was heavily relying on previous year questions, and that goes the same for orthopedics as well. We had a few questions from nerve injuries, from lower limb trauma and tumors, and one metabolic disease. The questions were from classic topics, nothing new, nothing extraordinary. Maybe a new question was there, but we'll try to find out and see if it was actually new or not. So the thing you need to remember about recall topic discussions is that these questions have been recalled by the students who've appeared for the exam. And nobody has 100% watertight memory. There can be a few words that are missed here and there, but nevertheless, the theme of the question, the MCQ options are what have appeared on the exam. So if the answers that I discuss here today on the recall might not match with what you have marked and you think that was the right option, maybe you're right, maybe I'm wrong. Doesn't matter. The point is we are here to understand what the examiner is asking so that we are well prepared for the future exams. So let's look at the first question here. What is the correct pair for the image shown below? So this looks like a spotter question and they're asking the correct pair for this image shown below. So what does this image look like to you? You really need to know this to be able to answer this. Right? Is it knuckle bender splint used in ulnar nerve injuries? Is it knuckle bender splint used in median nerve injuries? Is it cock-up splint used in radial nerve injuries, or a turnbuckle splint used in Volkmann ischemic contracture? So let's see what it is. So it looks like a splint there, okay? And focus on the wrist and the fingers. The wrist and the fingers are extended here, okay? So this is your classical cock-up splint which we use when the patient has a wrist and finger drop, which occurs because of radial nerve palsy. So the correct answer is cock-up splint used in radial nerve injuries. Now some of you were confused between cock-up splint and knuckle bender splint, so it is my job to make it easy for you. So first look at this patient. What do you see here? You see that there is a humerus fracture and the radial nerve that gets entrapped at the junction of upper 2/3 and lower 1/3 of humerus fractures gets entrapped here at the fracture site, and this fracture is known as Holstein-Lewis fracture. You know that. We are not here to discuss that. Whenever the radial nerve is injured, particularly at the spiral groove in Holstein-Lewis fracture, the patient will have wrist drop. And whenever you have wrist drop, you will have finger drop, thumb drop, as well as sensory loss. That's what we have remembered. Now there are two varieties of cock-up splint, but both of them the theme is the same. You are extending the wrist and the fingers, and this is a static splint, static cock-up splint, and this is a dynamic cock-up splint. In a dynamic cock-up splint, you will notice that there are either strings or springs or rubber bands to extend the fingers whenever you flex it. The aim is to keep the wrist and fingers in extension. Now, in a patient who has a wrist drop, he is unable to extend the wrist and the fingers, but his flexors are fine, right? His flexors are fine. But if he flexes his finger and wrist, he will be unable to extend it. So the cock-up splint that is dynamic, it has springs, strings, or rubber bands to extend the finger on behalf of the extensors that are lost. So the patient can comfortably flex the fingers, but the extension will be brought about by the springs, strings, or rubber bands. This is the dynamic nature of the splint. The advantage of using a dynamic splint over a static cock-up splint is that the dynamic splint allows the patient to continue using the flexors so that there will be no wasting and contracture of those flexors because of disuse. Right? So there will be no disuse atrophy because you will be using your flexors. That is the advantage of using a dynamic cock-up splint over a static cock-up splint. So if you look carefully, the patient has the wrist in extension and the fingers are also being extended, and you can clearly see that there are springs. I'm showing you the image from different angles. You can see these are the springs that will keep the finger in extension whenever the patient tries to flex the fingers. And these are the springs that will keep the wrist in extension whenever the patient brings the wrist into flexion. So this is your dynamic cock-up splint. Now, if you're confused between this and the knuckle bender splint, this is what I want you to look at. So what is this deformity? This is a deformity where the patient has a hypothenar wasting and extension of the MCP and flexion of the PIP and DIP. This, my friends, is partial clawing of hand. So the knuckle, that is the MCP, is in extension in claw hand. So you would want a device that would bend the knuckle so that it can counteract the action of the muscles that are contracting, right? So you would need a knuckle bender splint in a patient with claw hand. So you would want to bend the knuckle. So this is knuckle bender splint. So if you look carefully, what are you doing? You're bending the knuckles here. You're bending the MCP joint. So you'd want to bend the knuckle. You'd want to bend the knuckle because if you don't bend the knuckles, the knuckle will go into extension as it would happen in clawing of hand. So this is knuckle bender splint. So now contrast them. Now look at it and contrast them. You want to bend the knuckle here. So knuckles are bent here. Knuckles are extended in cock-up splint. Knuckles are extended in cock-up splint and the knuckle is bent in the knuckle bender splint, which we use in ulnar or ulnar plus median nerve palsy because of partial or complete clawing of hand respectively. Now let's look at the second question. A female patient complains of tingling and numbness in the lateral 3.5 fingers. She usually wakes up in the night because of pain. She gets relief by hanging her hands at the edge of the bed. What is the correct pair of diagnosis and the clinical test that can be performed? So this is a clinical we need. We are giving you a history of a patient and they're asking you what is the diagnosis and what is the test that you can perform. So female patient, tingling and numbness in the lateral 3.5 fingers. So finger 1, 2, 3.5, right? These fingers, there is tingling and numbness. And she usually wakes up in the night because of pain. This is a classical complaint of such patients. And what does she do? She gets relief by hanging her hands at the edge of the bed. What do you imagine this is? Even before looking at the options, I know the diagnosis is carpal tunnel syndrome, right? Middle-aged females complaining of pain in the night, right? Lateral 1, 2, 3.5 in the median nerve distribution area. This is carpal tunnel syndrome. So the option is, the pair is carpal tunnel syndrome, Froment sign, Guyon's canal syndrome, Durkan's test, carpal tunnel syndrome, Durkan's test, Guyon's canal syndrome, Froment sign. Which pair is accurate? Obviously, it's not Guyon's canal syndrome because Guyon's canal syndrome affects the ulnar nerve, right? Now, is it carpal tunnel Froment sign, carpal tunnel Durkan test? Froment sign, if you remember, is the test that you perform for ulnar nerve, the book test, right? Where the adductor pollicis is being tested. So the correct answer here is carpal tunnel Durkan test. So if you have attended my class or watched my videos, you would know everything about carpal tunnel syndrome. What is it? It is basically an idiopathic condition where there is pressure over the median nerve in the carpal tunnel. Why does it occur? We don't know. There are certain other associations. These are the associations. Usually females, particularly middle-aged females, and these patients complain to you pain in the middle of the night. Pain in the middle of the night, particularly in the median nerve distribution area, that is this 3.5 fingers. Now she will complain of pain, tingling, numbness, pins and needle-like sensation in the middle of the night. So these patients who have carpal tunnel syndrome, they get up because of the pain and they do quite a lot of things. They would either flick their hands or wrist like this. It's called a flick sign that will help them relief of pain. They would hang their hands at the edge of the bed to get some blood supply to the hand and the pain comes down. Or they can slap their arm or their thigh to get rid of this pain. Or some of them even massage their wrists with the other hand to get rid of the pain. Now, when these patients come to you and tell you, sir, I have this pain that usually happens to me in this area, do you trust the patient? Obviously not. You have to perform provocative test to confirm the diagnosis. And the tests that I've told you are few: Phalen's test and reverse Phalen's test. Remember, Phalen's test and reverse Phalen's test. But the best clinical test is to press on the median nerve to reproduce the symptom. This is known as Durkan's test. This is known as Durkan's test. This is the best clinical test. Obviously, the investigation of choice is nerve conduction studies. So this is the Durkan test being performed where you press on the median nerve directly, direct median nerve compression test. And the moment you press on it, after a few seconds, the symptoms will reproduce and the patient will tell you, sir, exactly like this, my symptoms occur in the middle of the night. Okay, now look at this. A patient complains of knee pain for the last 3 months. There is no history of trauma. Following is her radiograph and what is the correct pair of diagnosis and management. So there is a sequence here. All of these questions, they are asking the pairs of diagnosis and treatment, or diagnosis and the clinical test. So it's becoming more and more clinical nowadays, right? So this was the image apparently that was shown to you on the exam, and students have told me, and I kid you not, that the image that was shown actually had the diagnosis written on it. So I'm assuming this was a mistake made by the exam, and if it were a mistake, hopefully all of you should get a mark for this, and if you don't, none of you should get a mark for this. But whatever it is, there was an apparent mistake here, and some of you started overthinking that this is not a mistake and they're probably testing you something more challenging and difficult, and then you started overthinking and marked the option wrong. Nevertheless, let's see what this image or X-ray is showing you. So this is an X-ray where they are showing you the AP view and the skyline view, right? The skyline view, where you see that there is a discontinuity at this part of the patella. Okay, so they're asking diagnosis and management. So diagnosis is avulsion fracture of patella, which requires tension band wiring. It's a fracture of upper pole of patella, requires cast placement. It's an avulsion fracture of patella requiring interfragmentary screw fixation. Or is it bipartite patella? Advise X-ray of another knee. See, if it were a fracture, there would be history of trauma, right? But there is clear mention that there is no history of trauma. And I think this is the clincher here. And the other clincher obviously is the mistake that the examiners made. They gave the word bipartite patella here. So the correct answer is bipartite patella, advise X-ray or radiograph or the other knee. Now let's see what this bipartite patella is all about. You see, bipartite patella is basically a congenital anomaly where the patella has an accessory nucleus. Okay, accessory ossification nucleus. Usually patella is a single ossific nucleus which ossifies and becomes a patella. But here, because of some congenital anomaly or developmental anomaly, there is an accessory nucleus that does not completely fuse with the primary nucleus. Okay, this is not very common, it's rare, but it does happen. And when that happens, usually the symptoms are not there. So it's an incidental finding. So the nucleus that is separate from the patella can be at the lower pole, can be at the lateral side, or can be at the superolateral. This is the most common type of bipartite patella. So on X-ray, you can clearly see that there is a separation here. And this usually is bilateral. In fact, more than half of the patients, more than 50% of the cases are bilateral. The interesting thing is the patients do not have any history of trauma. Okay, usually they do not have any complaints, but if at all they have chronic pain. Okay, they have chronic pain and there is no history of trauma. And when you get an X-ray because of pain, you will notice that there is some gap. And you take a contralateral X-ray of the other knee and usually both the knees are affected. And this is what bipartite patella is. So it's an anomaly where the patella has an accessory ossific center which does not fuse. Unfused patella is usually at the superolateral pole. That is the most common type. It's actually type 3 of bipartite patella. It's an incidental finding on radiograph and it's bilateral in more than half of the cases. Patient rarely have any complaints, and if at all they do, very rare, they have pain only. Treatment is usually conservative. No intervention is required. Now, before we close this MCQ, I want you to look at this X-ray and tell me what this is. This is a lateral view of the knee, right? This is the femur, right? This is the tibia, this is the fibula, and this bone over here is the patella. And if you notice, patella is fractured here. So there is a fragmentation, fracture and separation of the fracture fragments. So I don't want you to confuse patella fracture with bipartite patella. Bipartite patella has smooth edges, whereas patella fracture will have ragged or jagged edges because it's a fracture. Now, can you recall the treatment of patella fracture? Yes, absolutely right. Open reduction, internal fixation with tension band wiring, right? Why do you use tension band wiring? Because this is a device that will convert the distractive forces acting on the patella by the quadriceps tendon and convert them into compressive forces. So it's a device that converts the distractive forces into compressive forces. So that is the most common type of patella fracture where there is a transverse fracture and the fracture is displaced. And the most common treatment for patella fracture is tension band wiring. So if on your exam ever in the future they say patella fracture, the first thing that should come to your mind is tension band wiring. Now there are certain other treatments also that you can offer to patella fracture. If the patella fracture is an undisplaced fracture, you can manage it conservatively with a leg cylinder cast. And if it's a transverse fracture that is displaced, you have to go with tension band wiring. And if it is a comminuted fractures with multiple fragments, then you cannot reduce and fix them. So might as well go and remove it. That is patellectomy. But the most common fracture pattern is the transverse fracture pattern, and the most common treatment for patella fracture is tension band wiring. So that is a keyword you should remember for your exams. Okay, moving on to the next question. A 22-year-old female presented with swelling in the forearm. All right. Now the radiograph is given below. What is the likely diagnosis? So what kind of a question is this? This is a spotter question with only one clinical point mentioned to you, that it's a female who's 22-year-old and this is the X-ray given to you. So if you can't read the X-ray, you'll be unable to diagnose this or answer this question. So let's read the X-ray. But before we read any spotter kind of MCQ, we have to look at the options. What are the options? A giant cell tumor, aneurysmal bone cyst, chondroblastoma, osteochondroma. So they are talking about a tumor over here. So look at the X-ray. So this is a radiograph of which part of your body? Right, wrist. You can see the radius here. You can see the ulna here. These are your carpal bones. These are your metacarpal bones. Very good. Now, this is a mature skeleton or immature skeleton. Right, this is a mature skeleton. How can you say that? Because the growth plate is not visible, which means it is fused. So this is a mature skeleton, adult, right? Now, where is the pathology? It's in the radius. Very good. Which part of the radius? Distal end of the radius. Yes, particularly epiphysis, metaphysis or diaphysis. It's under the articular surface, right? So it is epiphysis. So epiphysiometaphyseal. So it is an epiphyseal lesion. Epiphyseal lesion in an adult skeleton at the distal end of the radius. What is the first thing that should come to your mind without any doubt? It is giant cell tumor, without any doubt. Remember, the epiphyseal tumors are chondroblastoma and a giant cell tumor. Chondroblastoma occurs in skeletally immature patients, that is children, and giant cell tumor occurs in skeletally mature patients, that is adults. And how can you differentiate? Based on the growth plate. If the growth plate is visible, you mark chondroblastoma. If the growth plate is not visible, you mark giant cell tumor, as long as the lesion of the tumor is in the epiphysis. You know this very well, right? But nevertheless, most of you will get confused between ABC, GCT, chondroblastoma and osteochondroma, and it is my job to simplify it for you. So look at this first image. Now what is this? There is 1, 2, 3, 4 images. Let's look at each image one by one and learn how to practice. This is important. So image number 1, X-ray, right, of the wrist. Very good. Mature or immature? Mature skeleton, because the growth plate is fused. Where is the lesion? Lesion is in the ulna. Very good. Distal end of the ulna. Epiphysis, metaphysis or diaphysis? Yes, it is an epiphyseal lesion because just under the articular surface. So this is epiphyseal lesion in mature skeleton. This is giant cell tumor. Very good. Now what about image 2? X-ray, wrist, adult or child? Adult. Lesion in the radius or ulna? Radius. Which part of the radius? Distal end of the radius. Epiphysio, metaphyseal. Classical soap bubble appearance is also seen. This is your giant cell tumor. Similarly here, what is this? Image number 3 is an X-ray of knee joint, right? This is the femur. This is the tibia. This is the fibula, right? Mature or immature skeleton? Mature skeleton because the growth plate is not visible. Lesion is in the epimeta or dia. It's in the epiphysis because it's just under the articular surface. This is again giant cell tumor. And finally, image number 4, X-ray of the wrist. Mature, immature. Mature, lesion in the ulna. Epiphysis of the ulna. This is again giant cell tumor. This is what you should know. If you follow this step by step, the answer will be in front of you. Now look at this. Look at this series. Image number 1, 2, 3. Now image number 1, X-ray, right? Knee, right? This is femur. This is tibia. Very good. This is fibula. Lesion is in the distal femur. Mature or immature skeleton? This is important. Growth plate is visible. Growth plate is visible. So it must be immature skeleton. Lesion is in the metaphysis. Multiloculated lesion in the metaphysis. What do you think this is? This is aneurysmal bone cyst. Same thing goes for this. What is this X-ray? Right. Of which part of the body? Around the ankle, right? So this is the tibia, this is the fibula, this is the talus. Growth plate is open or closed? It's open, must be a child. There is a lesion in the metaphysis, multiloculated, multiseptate. Again, this is aneurysmal bone cyst. Okay? अब ये देखो, third image. This is femur, this is tibia, this is fibula. Mature or immature skeleton? Immature skeleton because the growth plate is visible. Epiphysis is absolutely normal. Lesion is in the metaphysis, multiloculated, multiseptate. This is your aneurysmal bone cyst. Okay? I've made you practice so many. Now what about this? What is this? This is an X-ray. Very good. Which part of the body? Knee joint. Very good. Very good. Mature or immature skeleton? Growth plate is visible na? So this is immature skeleton. Bachcha hai. Right. Lesion. Where is the lesion? Lesion is epiphyseal. So epiphyseal lesion can be chondroblastoma or giant cell tumor. If it's a child, chondroblastoma. If it's an adult or a grown person, then it is giant cell tumor. So this is a child. So what do you think is the answer? It is chondroblastoma. And lastly, what is this image? Again, this is an X-ray. Very good. Of which part of the body? Knee, right? This is femur. This is tibia. This is fibula, right? Adult or a child? Skeletally mature or immature? Skeletally mature because the growth plate is fused. And what is the pathology now? There is a pathology. There is a growth around the metaphysis, which looks like it has a pedicle and a cartilaginous cap. This is your osteochondroma, friends. Osteochondroma. Right? This is your osteochondroma. Now I'm sure you have understood the differences between these lesions. The theory you know. This is spotter question. You have to be able to diagnose this on image. Last image before we go. Look at these two images, image 1, image 2. Chalo batao, what is image 1, what is image 2? Image 1 is an X-ray. Right. Which part of the body? Knee, right? Mature or immature skeleton? Immature. How can you say that? Growth plate is still visible. Growth plate is still visible. Lesion is in epiphysis, metaphysis or diaphysis? Lesion is in the metaphysis, multiloculated, multiseptate expansile. So what do you think it is? It is aneurysmal bone cyst. In contrast, look at this. This is an X-ray of the wrist. Mature or immature? Mature skeleton. Why? Because the growth plate is fused, it is not visible, and the lesion is in the distal end of the radius, starting in the epiphysis just under the articular surface. So epiphyseal lesion, moving into the metaphysis. So epiphyseal lesion, multiloculated, multiseptate. This is your giant cell tumor. Now I hope these images are very clear to you. Giant cell tumor is one of those tumors that will show up in each and every of your exams, so you should know everything about it, and the first step is to make the correct diagnosis. Now next question, a child presents with deformity in the lower limbs. Okay, a radiograph is shown below. He also has hypopigmented patches on the skin. What is the likely diagnosis? This is the X-ray given to you. So what kind of question is this? Again, a spotter question, but there are two things that are mentioned here. Child with deformities in the lower limb, that is one hint. Second hint is he has hypopigmented patches on the skin. So skin changes, skin lesions with deformity in the lower limbs. X-ray, it looks like this is an X-ray of pelvis with both the lower limbs. But before we look at the image, we have to look at the options. Fibrous dysplasia, non-ossifying fibroma, Paget's disease, osteogenesis imperfecta. Now before we go any further, we can rule out one option easily. Which one is that? Paget's disease, because this is a disease that occurs in elderly population, adults, right? More than 60, more than 70-year-old, that age group. So it cannot be Paget's disease. So is it fibrous dysplasia, non-ossifying fibroma, osteogenesis imperfecta? Osteogenesis imperfecta, what should you remember? Blue sclera, multiple fractures in different stages of healing, fragile bones, that is what you should think of, right? Non-ossifying fibroma, fibrous dysplasia. Fibrous dysplasia, what is a classical X-ray finding? Shepherd-Cook's deformity, and that is what it is. This is your Shepherd-Crookes deformity, right? This is your Shepherd-Crookes deformity. So the diagnosis here is fibrous dysplasia. Now fibrous dysplasia, Shepherd-Crookes deformity, I know sir, but what is this hypopigmented patches? Hypopigmented patches, where did we read this? It's a part of a syndrome. Which syndrome? Right, McCune-Albright syndrome. So this is the Shepherd-Crookes deformity, and this is the Shepherd's crook, which he uses to control his cattle. The syndrome that we are talking about is McCune-Albright syndrome, where the patient has polyostotic fibrous dysplasia. So fibrous dysplasia involving multiple parts of the bone or multiple bones. Pigmentation on the skin in the form of cafe au lait spots. Remember, cafe au lait spots. And finally, the last P is precocious puberty. Right? So these are the 3 P's of McCune-Albright syndrome. Another important MCQ here is, in fibrous dysplasia, what is the biopsy finding? Right? It is Chinese letter pattern appearance. Chinese letter pattern appearance. Okay. So the last question is, a child was brought with deformities as shown in the picture. Which of the following vitamin deficiency causes it? Again, what kind of a question is this? Spotter question. You cannot answer this question without understanding what this image is showing you. So what is this image showing you? The image is showing you, but before looking at the image, let's look at the options. Vitamin A, D, K or E. So they are asking the deformity that is in the image is because of which vitamin deficiency. So what is the image showing you? It's child, obviously, because question also has mentioned child, and it's an image of the lower limbs. And what do you notice? This is the thigh, this is the leg, this is the thigh, this is the leg. So what is the deformity that a child has? This is the midline, and the legs are going towards the midline. What is this? Varus deformity. The knee is used as a reference. So this is bilateral genu varum deformity. A child with bilateral genu varum deformity, what is the first thing that should come to your mind as a doctor? Rickets. Rickets. So if you can quickly recall rickets, what do you remember about rickets? Rickets occurs because of vitamin D deficiency or calcium deficiency or phosphate deficiency or magnesium deficiency, whatever it is. But the most common cause is vitamin D deficiency. And what is the most common cause of vitamin D deficiency? There are many causes like nutritional hair, lack of sunlight exposure, malabsorption, liver failure, kidney failure. But what is the most common cause of vitamin D deficiency? It is nutritional. Patient is not consuming enough vitamin D. It's a vegetarian diet. His vitamin D is deficient. Okay. So what is the manifestation? The manifestations are swelling around the joints, remember? And why do these swellings around the joint occur? Remember, there is a cupping, splaying and fraying and widening around the wrist, right? Why? Because remember, if you have attended my classes or watched my videos, you'll remember that the growth plate has certain layers, right? Germinal, proliferative, hypertrophic, calcification, ossification layers. And this is the direction of growth from epi to meta. Germinal is fine, proliferative fine, hypertrophic is fine. But since there is deficiency of vitamin D, hence deficiency of calcium, the hypertrophic layer is not getting calcified. So the hypertrophic layer keeps on getting hypertrophied, and that is when it pushes through the metaphysis, causing the cupping, splaying, widening and the fraying. And that is what is visible clinically as swelling around the wrist or joints. On X-ray, it will show you the classical cupping, splaying, fraying and widening. But the moment you give this patient vitamin D and calcium, what happens? The calcium gets absorbed in the hypertrophic layer and it becomes layer of calcification. So what you will notice on X-ray is this dense white line. This is known as white line of Frankel, which suggests that the patient is healing from rickets because of the treatment of vitamin D. But this white line of Frankel is also seen in scurvy. It is also seen in scurvy, which is vitamin C deficiency. Vitamin C deficiency. So how do you differentiate between vitamin C and D deficiency? Two places. Clinically, how will you differentiate? A vitamin C deficiency patient will have collagen abnormalities. So bleeding comes, endothelial damage, so bleeding, petechiae and rashes, that will be there. Whereas vitamin D deficiency patient will not have bleeding disorders. Radiologically, what will you notice is in the epiphysis, there will be a ring that will be surrounding the epiphysis that is known as the Wimberger's ring sign. Wimberger's ring sign seen in scurvy. Now, can a patient have both vitamin C and D deficiency in combination? Yes, it can be possible. And remember that disease. What is that disease? That is known as Barton's disease. So Barton's disease patients have both vitamin C and D deficiency, not to be confused with Barton's fracture, which is an intra-articular fracture of the distal end of radius. And before I close this question, there are 6 MCQs that you should know regarding the deformities. So this is a child with bilateral genu varum deformity. This is a child with bilateral genu valgum deformity. And this is a child with wind-swept deformity. The MCQs are, what is the most common cause of bilateral genu varum in children? The answer is rickets. Right? And in adults, the answer is osteoarthritis. What about bilateral genu valgum? It is actually idiopathic more than rickets. In adults, it is rheumatoid arthritis more than osteoarthritis. And wind-swept deformity, remember, in children occurs because of rickets and adults because of rheumatoid arthritis. So these are the 6 MCQs that they can ask you around the deformities of the knee. Now, those were the questions that were purely orthopedic questions. There were a few more anatomy, radiologically anatomy linked with orthopedic kind of questions also that will be discussed with my other colleagues on the platform. Nevertheless, what you have found out is that most of the questions were from previous year topics. So mastering the previous year topics is essential for any preparation of any exam on any part of the world, right? In any part of the world. With that said, don't be disheartened if you got them wrong. You still have time to recover and improve. There is INI coming around the corner, and I wish you all the best, and I will see you on the other side. Till then, take care. Thank you. Bye-bye.